NAFLD is a relatively young disease. We don't have much literature or experience before 1980, since it came into use after 1980. But we are having an expanding number of people with diabetes, obesity, and India is the diabetes capital, if I am not wrong. So we have huge number of patients with almost all the metabolic syndrome parameters, predominant of which is diabetes and obesity. So because NAFLD is a component of that same metabolic syndrome, and it's a co-passenger, you can say, with diabetes and obesity. So we expect a lot of cases of NAFLD, not now, even in for last 3 to 4 decades. And so our experience also says that we are seeing more and more patients of non-alcoholic fatty liver disease rather than perhaps alcoholic and viral hepatitis combined together. So with such an expanding number of NAFLD, it's very likely that the NAFLD people will be seen by both endocrinologists, diabetologists, us hepatologists, as well as the primary care physicians and general physicians. So we need some integrated approach and what people usually call a clinical care pathway. Because if there is an approach which is scientifically based and robust and easily accessible and could be followed easily and approachable by all, then the management could be streamlined. So for streamlining the management, you need a clinical care approach. And for that approach, whatever the study says, that non-invasive assessment is very important, because you cannot do liver biopsy in all the patients. There are risks of liver biopsy, it's not feasible. Most of the centers don't have access, primary care physicians don't have access to the liver biopsy. It's only done at our centers, at tertiary reference centers. So FIB4 as a non-invasive marker is very good, at least to screen, because see, not all NAFLDs will progress, but certainly a percentage will progress. And how to know who will progress? Clinically, there are very few pointers, but you have to know the situation, what is happening inside the liver. The biopsy is best, but not feasible. So as an alternative to biopsy, we have these non-invasive markers, and amongst all these non-invasive markers that have been extensively studied, including APRI, FIB4, NASH fibrosis score, which is abbreviated as NFS, as well as there are other Bird index. But amongst all this FIB4 has been extensively validated, and I think most of the scientific communities and the societies heavily rely on this FIB4 to risk stratify this patient, because risk stratification is important, because we are a country with meager resources. You cannot treat every patient, because every patient will not develop advanced disease. So who will develop advanced disease? What is actually happening inside the livers? And FIB4 in this aspect is the best way to identify actually what is happening to liver and whom to take further for treatment or further evaluation. So we as a hepatologist, we are always in favor of FIB4 to initial risk stratify our patient. But FIB4 is not the end. Once people are on intermediate or high risk on FIB4, they should be subjected to further screening, further risk stratification by using something called fibroscan. UDCA, I think in this country is extensively used, rather misused, and it is almost every conditions related to liver. Regarding NAFLD, we don't have data to support its use in non-alcoholic fatty liver disease. Now, if I look upon the world data, we have very few studies, Dr. Banerjee Center, where they have used UDC in the dose of 25 to 35 milligram per day, and I believe using that high dose is not cost benefit in this country. They have shown some reduction in liver enzymes, particularly ALT, when used for 3 months at a very high dose of 25 to 35 milligram. That makes somewhere around 1200 to 1500 milligram in tablet forms, and that too only for 3 months, only reduction in ALT, no effect on fat, no effect on fibrosis either. And most of the people, when they are out of UDCA, again the ALT starts rising. So it has a very minimal effect, even in very high dose, just for a 3 months period of time, and the effects doesn't accrue over a period of time. So UDCA has very limited role, if any. We need better studies. In India, we had 3 studies on UDCA, one from Orissa, another PGI, another Dr. Sarin's group. All the 3 studies recruited very small number of patients. Most were open label studies, observational studies, and though the data were very encouraging, but I think we should not form any decision based on those small studies. See, saraglitazar has been approved for diabetic dyslipidemia for long. So it is diabetes and dyslipidemia. So you already got an approval for a condition where there are 2 components of metabolic syndrome present. And nowadays, it's what my practice says, it's difficult to get any people who is having non-alcoholic fatty liver disease as a non-diabetic and non-dyslipidemic. See, nearly 50-60% are diabetic and nearly 30-40% are dyslipidemic. So altogether 70-80% people of non-alcoholic fatty liver disease are either diabetes or impaired fasting glucose or impaired glucose tolerance or insulin resistance in some way or dyslipidemia. So logically saraglitazar must have a good role, and that is the reason most of the Indian scientists, researchers are interested working on saraglitazar. Saraglitazar should be used in non-alcoholic fatty liver disease, particularly in those group of patients who are diabetic, because we all know that vitamin E is not recommended for diabetic NAFLD. Pioglitazone is recommended, but pioglitazone has its own sets of side effects, and their side effects are many, because nowadays even diabetologists are afraid of writing saraglitazar because of the risk of pedal edema, weight gain and some cardiac compromise. So yes, and also osteoporosis and fracture risk, particularly in elderly postmenopausal females. So in diabetic, in dyslipidemic group of NAFLD where you cannot write vitamin E, I think saraglitazar has a role to play, and saraglitazar is strongly recommended if the patient needs therapy based on their risk category. Now, in my opinion, saraglitazar has a bright future. So when we started working on saraglitazar 1 year back, that time it was just approved by INSL in December 2022. There was rumors doing around that it will be approved by INSL. Subsequently, it got approval, and there was hardly one pharmaceutical houses promoting this brand. But that time we realized that saraglitazar has this good potential, strong potential, and future prospect. So I think for next maybe 5 or 10 years, unless we have better medications like which people are usually working, chemokine receptor blockers and all these thyroid receptor agonists, or other group of fibroblast growth factor, etc., unless those group of drugs are available and have been shown to be very useful, saraglitazar is going to rule the market and our practice also for next 5 to 10 years. The saraglitazar is very useful drug for a group of people who are having F2, F3 fibrosis. I think F0, F1 we don't need therapy, we don't offer therapy. Saraglitazar is very good for F2, F3 fibrosis. In my experience, over a period of 3 months or 6 months, maybe 3 to 6 months, most of the people have a very good resolution in their F2, F3 fibrosis. Regarding reduction in ALT, I think saraglitazar is not that useful as it is in reduction in fibrosis, but yes, some amount of reduction in ALT also happens. But I'm still skeptic about the role of saraglitazar in F4 fibrosis. If you analyze the data, we have very minimum of data on F4 fibrosis, and that too is not based on biopsy, it's based on fibroscan values, because there is only one paper in India which has shown that in F4 fibrosis, though there are only 10% of all people are F4, out of 100 plus patients, only 10% are F4, and they have shown some improvement in F4 fibrosis as well, significantly compared to placebo, but that was documented only on fibroscan, not on liver biopsy. I still have doubt how much it works in F4, but saraglitazar is a very useful drug to bring down the extent of fibrosis, at least in F3 and F2 fibrosis, if you give the drug for at least 3 to 6 months.